So the next topic is on C. diff infection and fecal transplantation. So Clostridioides difficile. So the new name is not Clostridium difficile, it's Clostridioides difficile infection. It's a gram-positive rod, anaerobic, spore-forming, toxin-producing. And the main modes of spread is fecal-oral route and fomites. Okay, the mortality is up to 35%. So it can be a colonizer in few hospitalized patients also. The risk factors being age more than 65, previous hospitalization. Main risk factors is recent antimicrobial therapy, especially clindamycin, fluoroquinolones, second generation cephalosporins, any antibiotic per se. So these are the main risk factors. Immunosuppressions and PPIs, proton pump inhibitors, CLD patients. So these are the high risk factors for C. diff infection. So mostly it colonizes in the large intestine. With adequate immune response, usually they are asymptomatic carriers. With the use of antibiotics, the microbial flora is altered, making the patient susceptible to C. diff infection. The transmission is usually via fecal-oral route, and the infection is mainly due to the enterotoxins, toxin A and D. Toxin A is enterotoxin, whereas toxin B is cytotoxic. So usually when there is colonization and toxin production, when the patient's immune response is adequate, it becomes a carrier stage. When the immune response is inadequate, the patient will have diarrhea and colitis. So based on several criteria, we can classify into non-severe, severe and fulminant infection, mainly based on WBC and creatinine. So if the white cell count is less than 15,000 and the creatinine is less than 1.5, it is non-severe infection. Severe, and the patient is the WBC count, white cell count is more than 15 and the creatinine is more than 1.5. Fulminant infection, when there's hypotension, shock, ileus, toxic megacolon. So frankly, septic and shocky. So that is fulminant infection. So how do you diagnose C. diff infection? So the main gold standard is culture. So culture and cell cytology neutralization assay. So this is something that can be considered. So these two are the main tests that can be done. But what is the disadvantage? The toxigenic culture and cell cytotoxicity assay. So the turnaround time is going to be more than 48 hours. It's 24 to, and it's not available on all centers. It's difficult to perform also. Okay, but it is very highly sensitive and it is the reference standard. So toxigenic culture is the gold standard. Cell cytotoxicity assay. So normally what we do in the hospital is the ELISA or the enzyme immunoassay. So this you check in for GDH and toxin A and B. So GDH is insufficient for diagnosis. Always toxins should be positive to diagnose the pathogenic state. GDH can denote a carrier state. Okay, other thing would be a nucleic acid amplification test. This is more expensive than enzyme immunoassay, but it is highly specific and sensitive for toxigenic C. diff. And next would be a RT-PCR for toxins. Okay, so how do you go ahead to diagnose it? So when the patient has C. diff infection, always contact isolation, hand hygiene. Remember, the chlorhexidine hand wash is not going to prevent a transmission because the spores are not going to be killed by chlorhexidine. Always hand washing is the important strategy that we need to maintain. So contact isolation, send NAT or EIA GDH test. So looking for GDH toxin. If toxin A and B are positive, it means C. diff is confirmed. If GDH is positive and toxin A and B are negative, it can be a carrier state. If GDH is negative and toxin A and B are present, it is positive. So remember that. So toxin is very important for diagnosis. If the results are inconclusive, go ahead with PCR or culture test. So possible causes for negative result would be if there is a false negative. So it could be due to low toxin levels, false negative EIA results, and it could be a carrier state also. So other things, so C. diff can cause pseudomembranous colitis and toxic megacolon. So colonoscopy, flexible sigmoidoscopy or colonoscopy can be done if the patient has persistent symptoms and abdominal distension. So pseudomembranous colitis is due to inflammation of the colon. Yellow-white plaques can be found in the intestinal mucosa. Differentials would be uremic colitis, ischemic colitis, irritable bowel syndrome, Behçet's. So it can be, pseudomembranes can be scattered or it can be confluent, okay, involving 2 centimeters or like confluent involving the entire bowel, and it can involve a greater depth also. So when it involves a greater depth, it's graded high. So sigmoidoscopy or colonoscopy usually useful in patients with ileus, paralytic ileus, and biopsy can help us diagnose. Contrast CT abdomen. So in case of toxic megacolon, so if the bowel colon is dilated more than 7 centimeters, it is known as toxic megacolon. There can be small bowel dilatation, air fluid levels, thumb printing, scalloping of the bowel wall, air under the diaphragm. If frankly the patient had a perforation, so peritonitis can be there. So air under the diaphragm, mural thickening. So these are complications: pseudomembranous colitis, toxic megacolon, and perforation of the abdomen. So what is the management strategies? When we look into the different guidelines, the IDSA or the SHIA guidelines is the guidelines that we normally follow. The European, this is Australasian guidelines. So each guidelines differ in their management. Normally what we follow is the IDSA guidelines. Initial episode, non-severe episode, consider vancomycin 125 milligram per oral 6th hourly for 10 days. If above agents are not available, you can give metronidazole also. The patient, it is a non-severe form of C. diff infection for 8 hourly for 10 to 14 days. Fidaxomicin 200 milligram dose can be given. Okay, in case of severe infection, adjunctive besletoximab, vancomycin 6th hourly for 10 days, besletoximab. So this can be given, or fidaxomicin alone. Okay. So if there is if primary C. diff infection and the risk factors of recurrence is high, if the patient is immunocompromised, age more than 65 or prior history, so then you will have to consider this form of treatment. If it is fulminant infection, so you have to give vancomycin a higher dose, 500 milligrams 6th hourly per oral, followed by metronidazole 500 milligram IV. So these two are combined, high dose vancomycin and metronidazole. And consider vancomycin per rectum if ileus is present. Severe complicated fulminant complicated fulminant refractory. So here there is no recommendation, but then if the recurrence happens, first recurrence and second recurrence, based on the recurrence, ideally for every week it has to be kind of pulsed and tapered off. So first recurrence, you'll have to give it for a period of 10 days and then adjunctive beslotuzumab if prior episode was within 6 months. So then again for the second recurrence, you'll have to give 3 drugs or either fidaxomicin, vancomycin at a tapered pulsed regimen. So every week you will be like coming down on the 4 times a week, then 2 times a week, like that. It should be pulsed and tapered off. So if there is more frequent recurrence, consider fecal microbiota transplant. Okay. So the dose of these drugs. So vancomycin 125 6th hourly, and this is per oral. Rectum 500 milligram in 100 ml of normal saline, 6th hourly as retention enemas. Bezlotoxumab as 10 milligram per kg IV during IV. Fidaxomicin 200 milligram 12th hourly for 10 days. So extended pulse regimen. How do you do the extended pulse regimen? So 200 milligram for 12th hourly for 5 days, followed by every other day for 20 days. That is alternate day. Tapered and pulsed vancomycin regimen, 125 milligram, 4 times a day, 10 to 14 days. Then 2 times a day for 7 days. Then once a day. So this is how it is kind of tapered off. Then once a day for 7 days, and then every 2 to 3 days for the next 2 to 8 weeks. So this is a tapered or the pulse regimen for recurrence. So the other guidelines recommend various other strategies. So we'll just follow the IDSA.